So what about chemo? So there are several options that we can think about. So the COMPEL study, it's an interesting study. So the study allows patients who progressed on osimertinib but non-CNS progression. So patients who have progression systemically, they continue they go to chemo, but they're randomized to OC versus no OC. So really the important clinical question of, is continuing osimertinib beyond progression truly helpful? Now, the data is going to be presented tomorrow. I got the data here based on the abstract, so I would encourage you to look at the presentation for kind of the finalized data. At least on the abstract, there was a PFS hazard ratio of 0.43. Now, the more mature studies, and now I want to say the COMPEL study is a small study, about 100 patients. Now, the more mature chemotherapy-based regimen studies are MARIPOSA-2 and HARMONY-A, of course. And in MARIPOSA-2, there's chemo plus or minus amivantamab. The HARMONY-A combines chemo plus or minus ivonescimab. And both studies have patients who progressed on an EGFR TKI alone. And we can see, response rate again in the 50 to 60% range, median PFS around 6-7 months. Certainly, there is trend for significant overall survival benefit for MARIPOSA-2. The caveat here is that there was no crossover to amivantamab. So that is the big caveat in terms of the survival benefit. Now, in HARMONY-A, we saw the data earlier today that there is a trend, but it's not significant. Now, I added TROPION-Lung5 here because it is a chemo regimen, at least in the US or ADC regimen, that we do have available. The patient population is a bit different because these are patients who have been exposed to chemotherapy. The response rate is decent in the 40% range with the PFS around 6 months. It really remains to be seen whether this response holds in our larger study. Usually in a larger study, the response rate tends to go down a little bit. So we have a number of options in terms of chemo. I think how we decide, there's not a clear winner if we look at all these different regimens. It's going to depend on what the patient has received previously. Has that patient started with chemotherapy? Has that patient started with amivantamab, for example? And then the decision will be based on whether in terms of the patient's acceptance of specific toxicities.